lunch, went out and had, some sunlight, looked at your trees or whatever you needed to do to make sure that you re-energized for the next session. In this session, the speakers that we have today for you come from various organizations. They're going to share different approaches to diversity, equity, inclusion, and of course, advocacy. They're going to talk to you about how data can be leveraged to move organizations closer to equity. We're very thankful to have them each here. We're going to give each of our speakers an opportunity to introduce themselves and share their prepared remarks with all of us. Then we're going to go into small group discussions and have our presenters float into those rooms so that they can also contribute to those conversations and share cross learnings, amongst all of us. And a quick reminder before we go into the breakout sessions, we will talk about, the group agreements, meaning that we encourage everyone to participate, and we'll go through that. In the meantime, if you do have questions, please put them in the chat so that we can ask our presenters to share their thoughts during the Q&A. And with that, I will go ahead and pass it off to Abner. And once everyone is done, and before we go into the chats, we'll go through the group agreements just so that they're fresh on everybody's mind. So thank you again, Abner, Madel, and Ajoa for being here. Abner, I'll pass it on to you.
Great, thanks very much. I'll just go ahead and share my screen. Let's see if we can put this. Can everyone see?
Yes.
So my name is Abner Mason, and I'm a founder and CEO of a company called Consejo Sano. We're headquartered here in Los Angeles, and we are a health equity company. The way we are trying to make our healthcare system more equitable is to help our clients to engage their patients and their members in a better way, in a way that takes into account who those patients and health plan members are. While we're headquartered in Los Angeles, we serve clients across the country. So I'm grateful for the opportunity to be part of this conversation, and I'm really honored to join my fellow panelists who are just fantastic. I've gotten to know them a little bit. And my comments are going to focus on pursuing health policy through a health equity lens, or put another way, pursuing health equity through policy. But before I dive into the policy discussion, I do want to say a few words about the work that I do at Consejo Sano. Our country, the US, has undergone a huge demographic change over the past 4 or 5 years. According to the most recent census, we're on our way to becoming a majority minority country. We'll get there in 2045. And interestingly, the previous census said 2050. So we're going to, according to the last census, says we're going to get there even sooner. But California is today already a majority minority state. So we don't have to wait to 2045. So is Texas, so is Nevada. We're on this path as a nation, and certainly it has caused challenges with our politics, but I think those of us in healthcare just have to appreciate that this is the country that we've become. This demographic change has happened, and it continues to happen. For instance, the Medicaid program in California is
Abner, you've muted yourself.
Oh, let's see.
You're
am
good.
I muted now? Okay, sorry. That just gives you a sense of the Medicaid program in California being 80% multicultural, gives you a sense of just how important it is that we accept this demographic change and deal with it. So while it's happened, our healthcare system just hasn't kept up with it, and that's the reality. And so today, our healthcare system, both in California and across the country, is just not well equipped to serve the country that we've become, and let alone the country that we're becoming. And that leads to poor health outcomes for people and higher costs for society. And so what we're doing at Consejo Sano, let me just change slides here, is we're trying to help our clients to address this issue. We are, a mission-driven company. We understand the country's multicultural, but healthcare hasn't kept up. And what's happened is that if you look at healthcare stakeholders, and I'm talking about health plans and health systems and large providers, the way they have dealt with this demographic change to date is an old approach that we sort of call the 1.0 model of patient or health plan member engagement. It's all about language, using the same content that's designed to build a relationship with that patient or that health plan member, and to navigate them into care, using the same language written by an English speaker for an English speaker, and maybe translating it into many different languages, but it's still the same message. And that one size fits all approach just doesn't work very well, mostly because it sends a clear signal to the patient or to the health plan member that who they are, their experience with healthcare, their trust for the healthcare system, their ability to access healthcare, their willingness to do it, the way the social determinants of health uniquely affect them, everything that makes them who they are. The way our current healthcare system works, it kind of sends a signal to that patient or that health plan member. Don't tell us that. We don't want to know. That's complicated. We're going to treat you all the same, and you'll just like it, and that's all. That's the only option there is. That kind of approach, that one size fits all approach, is just not working. And so we shouldn't be surprised that when we treat people like who they are doesn't matter, they're not eager to engage with us. So all we're doing at Consejo Sano is saying, let's stop doing that. We use data, a lot of data, public data and claims data, as well as a technology platform we built and a team we built that comes from the communities we're trying to serve. And we're just trying to give people a more personalized, customized experience. We connect with people using data to understand who they are at a deeper level. We design the content based on that, and then we send it to them in the mode they prefer. And basically, if you get the culture right, you get the language right, you get the mode of communication right, you can build trust with people. You can engage them in a more customized, personalized way and navigate them into care at the right time, the right place. So that's what we've been trying to do. But I have to tell you, we have run up against a lot of policy challenges. And so I want to turn now well, first I should just thank, the folks who keep me in business. And I just talked about this, how language and culture are two different things, and we focus on culture. I do want to thank, my clients. I wouldn't be here if it weren't for my clients, and some of you are at these institutions and these organizations. And so thank you very much for working with us. We've got great partners. We work with some of the largest health plans, Medicaid and Medicare Advantage across the country. We're trying to help our partners give their members and their patients that more personalized, customized experience. But I couldn't do what I do without our clients, and many of you, as I said, work with those organizations. So thank you. So let me move now to what the moment that we're in, and what I have been learning as I've been doing this work. We have all learned a lot over the past 20 months. The disparate impact of COVID on communities of color and low-income people, and the whole discussion around racial justice and health equity that took place during 2020 that started with the death of George Floyd. It's really presented us with what I think is a once-in-a-lifetime opportunity, certainly my lifetime, to move from talk about health equity to actually taking meaningful steps to create a healthcare system that is more equitable and that works for everybody. And there's a lot of, I don't think this is a shiny object moment. I think that we should be optimistic. I'm cautiously optimistic. I can tell you the way I have, the conversations I've had with our clients and our prospective clients in 2019 is completely different than 2021. It's completely different. Health equity is now a #1 issue. And so it's a moment that we should take advantage of. And I think one of the ways that we make sure that we take advantage of this moment is that we've got to change policies so that policies support the effort to make our healthcare system more equitable. Policy is the way you make sure this is not a shiny object moment. It's the way we make sure that we take advantage of this moment and create meaningful change. So I'll start first with some key policies that I think that we should focus on. First is interoperability. I think this is just really important. We have got to figure out a way to make data work for both the healthcare system overall and for individuals to whom that data belongs. The data belongs to the healthcare consumer. If you look at this slide, the average person sees like 18 different doctors before they're 65, and after they're 65, it's about 28 different doctors. And all of those doctors, for the most part, use different EMRs. They don't communicate with each other. It's difficult to exchange data. And when the pandemic hit, it was pretty clear that it was very hard to get a feel for how the pandemic was affecting people at scale, particularly communities of color and communities that were having a disparate impact, because we didn't have the kind of health information exchanges and data interoperability that we need to have. So one key, I think, policy is that we've got to start to see data as belonging to the healthcare consumer, and move toward policies that allow that data to be shared and put in one place so that the healthcare consumer has his or her data at their control, and then they can decide who they want to share that with. I know that data is the source of a lot of value for companies, and people are hoarding it, and there are lots of silos. There are businesses that build their whole business model around data. So this is not going to be easy for us to convince people that in those silos, and I'm talking about, when I say silos, I mean institutions and organizations and companies, to convince them that it is time to create a smooth flow of data, health data, and to make sure that the consumer controls their own data. But that moment, I think, has come, and we need to, all of us, be advocating for that. California just made some big steps forward. I won't get into the details of that, but we should be leading, and we're not. But the governor just signed some legislation that will put us on at least on a path to getting a statewide health information exchange, which is a key component. But there are lots of opposition. Believe me, there are a lot of stakeholders who see the data that they have about the patients that they see, or the members that they have, as theirs, and they want to keep it. The second policy is, if you look at this list, and this list was generated by my own company, we work with health plans across the country, and this is the data that's most commonly missing. We are still not collecting race and ethnicity and language data in the US. It's 2021, and we're still not, which means that it makes it almost impossible to really get a handle on health disparities, and to know where to focus our resources, and to measure the effectiveness of programs when we have resources to deploy. So we have got to find a way to convince the healthcare stakeholders across the country, and this starts with policy at the federal and the state level, that they need to collect this data. We are just kind of operating in the blind without it. So my second suggestion is we've got to get serious about this. There's a lot of talk about it, but we're not serious about it. We're not even collecting this data when it comes the way we should across all the states, even when it comes to COVID. And surely, you'd have thought we would have gotten our act together to do it for COVID, but we have not. And so my second suggestion is we need to, from a policy perspective, make this a requirement and incentivize people to collect it. Sometimes you need a carrot, but sometimes you need a stick. We need to, we need to make it a little painful for stakeholders if they don't collect this data. And then if we had a way of sharing this data commonly, that's where interoperability comes from. A person wouldn't have to give this data again and again and again. That's interoperability is so important. The second policy area I touch on is closing care gaps, and disparities that are in care, and health disparities that are connected to race and ethnicity. We know they exist. COVID showed us, dramatically the disparate impact of COVID, but we all know the reason COVID had an impact is because of all of the underlying disparities that existed in these communities across the country, even before COVID hit. So if we're going to do something about a problem that we knew existed, it's not like this is new. We've known that our healthcare system we have these kind of disparities in our country, and our healthcare system is just not closing these disparity gaps the way they should. We need to take some action. So one of the things I'd suggest is that we need to really get serious about closing these disparities, and I'd suggest that if we would tie the quality programs, particularly in Medicaid and in Medicare Advantage. So in Medicaid, it's the HEDIS program. It's the way that Medicaid managed care plans, and most of Medicaid in the country, as you know, is managed care now. So this would really dramatically change the way Medicaid managed care plans think about their responsibilities. If we could tie their HEDIS scores or have closing disparities be a part of, and I'm talking about race-based disparities and disparities based on ethnicity and income, if we could tie that to their quality scores. Now, of course, you need to collect race, ethnicity, and language data in order to do that, so you have a baseline. but we could create a flywheel effect where Medicaid managed care plans would see it as much more in their interest, both the right thing to do and financially the right thing to do, is to focus on closing these disparities. And they would all of a sudden, you'd see innovation start to take place in really significant ways if we could do that. So I think we need to do that for the Medicaid program and also for Medicare Advantage. The star rating system should be tied as well to closing health disparities across, and I want to be clear here, it's because, race, ethnicity, and income. If we can get baseline on across the population, then we could reward plans and health plans, because they play a really important role when they can close these disparity gaps, and they're in a position to do it, working with their networks. So I think, but this takes policy change, and I'm sure it's not going to, it's going to be a heavy lift. But this is the way, again, you create that flywheel effect. If you, in effect, made it almost impossible for a Medicare Advantage plan to get and keep a 4-star rating unless they showed progress on closing disparity gaps, or at least had programs in place to close disparity gaps. I don't want to be unreasonable here, but they got to take some step, right? And we should have some metrics around it. You would again see an amazing flywheel effect take place. So another example of a policy that would be, I think incredibly helpful would be to tie incentives to the quality programs in both Medicaid and Medicare Advantage. And that brings me to another policy I think that could really make a profound difference when it comes to health equity and making our healthcare system more equitable. We all know that the social determinants of health, these upstream factors, have a profound effect on healthcare. A person's health, depending on whose data you look at, it's like 80% determined by things that happen outside of the clinic, right? But today, it's been really hard for the healthcare system and for the plans and providers and others to really get beyond talking about investing in these social determinant of health or upstream issues, getting beyond talking about it and actually doing something. So this is another area where I think we could really see some significant improvement in terms of health equity if we could allow the health plans to invest some of the premium dollar, give them more flexibility, and so that they can invest in these upstream or social determinant of health areas. Now, the good news here, and there's good news, and I want to celebrate good news when it happens, Medicare Advantage, that program, which is a federal program, they have created an initiative. It's called Supplemental Benefits. It's relatively new, and it's wonderful. It allows Medicare Advantage plans to invest some of the premium dollar in these sort of in these upstream factors or non-clinical factors. So a use case for an example is you've got a senior, she's low income, maybe, for example, South Texas, and it's July. She's in a small apartment with no air conditioning. It's 120 in there. She's going to have a respiratory event. And the plan in the past has just kind of crossed their fingers and hoped for the best. But now that plan can actually do something. They can buy an air conditioner for her. They can install it in her apartment. They can even give her a little bit of money to help cover her electric bill if it goes up a little bit. That total cost might be $600, $700, but the cost of that respiratory event that puts her in the emergency room and then in the hospital is more like $15,000, $18,000. So for the Medicare Advantage plan, it's a no-brainer. They're like, well, this makes absolute sense. So we're going to make sure that we figure out who amongst our members have these needs, and that's a use case. Maybe it's a transportation need. Maybe it's someone who's got housing insecurity, and they're going to be put out. Well, they're low income. The rent isn't much anyway. And using another use case, if they live in Boston and it's winter, the plan might say, I would rather pay your $400 rent and keep you in your apartment than have you get put out. Because if you are put out because you don't have $400, you're going to end up in the emergency room not once, but many times. And that's going to cost the plan, it's going to cost me, the plan, thousands of dollars. And so it makes sense for me to do that. So it's wonderful that this program exists in Medicare Advantage. It should exist, this kind of flexibility in Medicaid. I mean, if there was any population where the social determinants of health, where it was important to address those needs, it should be in Medicaid. Now, there's, some state, I want to give North Carolina credit. They've done a 1115 waiver. So they applied to the federal government, to CMS, and went through a long process and finally got approved so that they could spend some of the premium dollar on social determinant of health issues. But do we have to really have 49 other states go through this lengthy, complicated process when we all know that it makes sense to give plans this kind of flexibility without that? And we've done it for Medicare Advantage. So another policy change, I would say that it's really important, it would be to, we've got to figure out a way to address these SDOH issues, because we're not going to achieve the goals that we have for healthcare if we don't. Another one is virtual care, and here, there's two issues. One is, I think it's wonderful. I work for a company, we're a health tech company, we believe in innovation, but the truth is a lot of the innovation in health tech has been designed for higher income people, and policy has worked in such a way that it's limited those innovations to higher income people. An example is virtual visits. So I'm using California as an example because we're all here. Pre-COVID, federally qualified health centers really couldn't get reimbursed for virtual care. The person had to as they say, cross the threshold, come in order for the FQHC, the clinic, the provider, to be reimbursed. Which is a shame, right? We've got this new capabilities, virtual visits, should create more access. This is an instance where technology should be creating more access, but because of policy, it didn't. So then the pandemic comes along and nobody can go in. And so the regulators changed the regulations and allowed FQHCs, federally qualified health centers, to do virtual visits. We did an enormous amount of outreach on behalf of FQHCs and plans to Medi-Cal members to get them to do virtual care for the first time. And we were able to generate about 60,000 telehealth visits, primarily telehealth. So my first point is we need to stop allowing innovation to only flow, or the benefits of innovation in healthcare to flow to wealthy people only, or higher income people. We've got to figure out a way to see these kinds of innovations through a health equity lens and figure out a way to make sure that lower income people can take advantage of them. And to people like me, entrepreneurs out there, we need to also be building solutions that can work for lower income people. And it is a smarter way to go. If you build solutions that work for lower income people, it's easier to take that solution and sell it to higher income people. If you build a solution for higher income people, it's almost impossible to kind of pull things out of it and make it work for lower income people. So it's actually a smart thing to do from an innovative standpoint, but from a justice and equity standpoint, we need to make sure that we are not letting what happened with telemedicine happen again, where it's limited to higher income people. We don't reimburse for it for lower income people. Now, going forward, I hope that the emergency regulations that allowed low income people to have access to virtual care stays in place, because you never know, we could swing back once the emergency is over. In terms of policy, we found that people preferred telehealth on the phone versus video overwhelmingly. Like when we did outreach to get people to use virtual visits, 10-1, they chose the phone. Now there's a whole host of reasons for that. I won't get into it, but the fact is that's what they want and that's what they chose, right? Well, the regulators, and some of you might be in those areas, so I love you too, but we got to make sure that going forward, we don't have a two-tiered system, because what we're hearing is that regulators are saying, well, maybe we'll reimburse for virtual visits, but we're going to reimburse higher for video than audio, than a telephone visit. And that's the opposite of meeting patients where they are, because whatever you reimburse higher for, just human nature, and Lord knows healthcare is like this, that's what people are going to do. That's the only thing they're going to offer. In fact, if you say you get paid this for video visits and this and a much lower amount for telehealth, soon the system will only offer video visits, but that's not what people want, particularly low income people. So I think it's really important that we see these policies through a health equity lens going forward, because we want to make sure that we don't make the mistakes going forward that we made in the past. We need to learn from what we've experienced over these past 20 months, because it can really help us shape a more equitable future. And I'll just close with One other, I got a couple others, but I'll be quick. One is text messaging. It's ridiculous that health plans cannot text their members. The way America communicates today is text messaging. Unfortunately, because of an old piece of federal legislation, the Telephone Consumer Protection Act, plans have for the last couple of decades been constrained, health plans, in their ability to engage their members, particularly low-income people who the only way they're going to communicate is text messaging. It's been a huge problem. It continues to be a problem. Now, the good news is the Supreme Court just ruled in April. This is fantastic news. A lot of people didn't see it, but the Supreme Court rules that the Telephone Consumer Protection Act, this federal legislation which prevents health plans and other healthcare stakeholders from texting their members and patients, the Supreme Court ruled it no longer applies to health plans. This is clear as day, the ruling. But here's the thing, the regulators haven't caught up, and even health plans, like I heard one health plan in California said to me, well, you know, Abner, I'm not regulated by the Supreme Court. I'm regulated by the Department of Healthcare Services. And until they tell me we can text, I can't text. So we need to get the plans and the regulators together, and we need to get caught up because people deserve better. It's the only way people are going to communicate. And so we need to meet them where they are. If we're unwilling to do that, then we're not serious about really providing care to people. And so just two other quick ones. Internet access, you know, because of what we've learned in the pandemic, so much went virtual. It may not all stay, 100% virtual. It's going to swing back a little bit. But healthcare is not going to be like it was going forward, like it was going forward, like it was pre-COVID. Virtual care is going to be an important part of healthcare going forward. And one of the things we need to do, if we're going to, provide some of this care virtually, we need to make sure that people have access to the internet. So we need broadband access, but even beyond broadband access, and we know that's a problem. And there's a piece of legislation in the Congress now, they're fighting over this. That's, in the infrastructure bill. Hopefully it passes. There's money to try to, get more broadband access. But if you don't have the money to pay for the plan, you still haven't gotten access, right? You might have the broadband to your house, but it's expensive. So I think we should, here's another suggestion. Internet access going forward should be a covered benefit. If we're going to say that this is the way people get their health care, it should be a covered benefit. And last, it still is amazing to me that we allow, for instance, people who are on SNAP, who qualify for SNAP, the Supplemental Nutrition Assistance Program, they don't automatically qualify for Medicaid, and the other way around. It's just, we make lower income people just go through hoop after hoop after hoop, and they have to go through redeterminations. We need to see these policies through a health equity lens. And if you were seeing it that way, you would say that anybody who qualifies for SNAP automatically qualifies for Medicaid. These are simple things that could be transformative in terms of our healthcare system. And I know I only got 2 minutes, so I'm going to finish by just saying, I know that, that's like 8 policies, they're big things. And I know you're saying to yourself, how on earth are we going to ever get these kind of things done? And I'm not saying they're easy to get done. If they were easy, they'd be done already. And we'd have a more equitable healthcare system, but they're not easy. But I'm just telling you this, that, there's an old African proverb that says, if you want to go fast, go alone. If you want to go far, go together. So I have my own version of that, so a creative license. So my version is, if you want to do little things, do it by yourself. But if you want to do big things, if you want to get big things done, you need allies, you need, team members, you need fellow travelers. And I think that's who's on this call here. We are fellow travelers. This is our moment, and we can get some of these things done together. I know they sound big, but working together, we can get some of them done. This moment there's never been a time when with respect to health equity, when it was a better time. We have more people committed to it. We have more corporate commitment in healthcare and across the economy. We have, more government commitment at the federal and at the state level. We have the better tools than we've ever had before, better technology than we've ever had before. This is our moment to get some stuff done. So I just want to encourage you to think big. You are blessed to have been through a program like CHCF. You've got, we have resources, we have abilities to get things done, and I'm just honored to be, on this journey with you. So thanks for listening to some of my thoughts. I'm looking forward to hearing my fellow panelists and to the discussion later. Thank you.
Thank you so much for that. We do have several questions in the chat that we'll get to, but next I'd like to pass it on to Medell to go ahead and provide your introduction and then of course your topic. Thank you so much, Abner.
So I don't know about you all, but I'm fired up after listening to Abner as well. And so it is my pleasure. I'm just going to switch screens really quickly. You all should still be able to see it, but it is absolutely my pleasure to be with you all today, as well as with my fellow panelists. So again, my name is Medell Briggs-Melanson, and I am the Chief for Health Equity, Diversity, and Inclusion for the UCLA Hospital and Clinic System, as well as an Associate Professor of Emergency Medicine at the David Geffen School of Medicine. And I'm here today to really discuss some of the journey that we've been on as an organization in order to not only embrace the principles of anti-racism and really promote health equity, diversity, inclusion, but also talk about organizational transformation and how that looks both on the inside of an organization, but what an organization can do to ensure that they're promoting health equity and racial justice for the patients and the communities that they serve as well. And so I'm going to go ahead and just continue on through the presentation. And just to give you a little bit of background, everyone's from, for the most part, California. So I'm sure that you all are familiar with our entire UC system as well as UCLA. But UCLA Health is comprised of 4, soon to be 5 different hospitals in the Los Angeles area, as well as over 200 clinics. There's also an additional 100 or so different affiliations with many of our other community organizations as well. And so my role as the Chief of Health Equity is actually to oversee all of the various different initiatives that occur both within the organization in order to promote inclusive excellence, as well as overall equity amongst our staff, our faculty, our trainees, and our students, but also making sure that we are creating that same type of inclusive, supportive, affirming environment in order to promote equitable care and equitable outcomes for all the patients that we serve. And then the third area that I actually oversee is also looking at our community partnerships, as well as looking at our diverse group of community investments in order to feed back into the community so that we can, in an effective way, think about and address all the various different social structural determinants of health and actually extend beyond our 4 walls of just providing clinical care to really doing things that are truly going to achieve health equity by addressing all the other factors. So just to begin, of course, this has been a very short journey that we've been on as an organization. I want to put that out there. And we all know that this thing right here actually caused our entire country and our entire world to be flipped upside down. And in addition to that, it was very clear in the COVID pandemic, as we all know, that COVID was specifically, although it was targeting everyone, it was specifically disproportionately impacting our communities of color, as well as our low-income communities. And then following with, of course, the surge of the COVID-19, we witnessed the deaths of George Floyd, as well as many other unarmed Black men and women directly on our phone screens, directly also through social media, which gave rise to one of the largest racial reckonings that we've seen in this country in a very long time, to Black Lives Matter, that is completely standing up against police brutality in this country, as well as all the additional social injustices that occurred. Well, during the same exact time, began to also embrace this itself, in which, along with many other healthcare organizations throughout the country, bonded and was saying that racism is a public health crisis that has been continuing, and we will stand up against racism. We will stand up against any other forms of bias and discrimination. Now, of course, during the same time, we also saw things that we've never seen in this country, such as the insurrection on Capitol, and literally the desecration and trying to dismantle many of our historic processes and democratic processes within this country. Followed, of course, coupled with the rise in anti-Asian racism and violence, especially against women and elders. And then also we saw rises in anti-Semitism as well as Islamophobia, not only here within California, as well as in the country, but also throughout the entire world. So with all these different things that were going on, UCLA Health in particular is like, it's time for us to recommit to actually doing what we know is right and actually be very intentional. So to provide a little bit about some of our journey as an organization, I always like to define equity, diversity, and inclusion. We call it EDI at UCLA, with the importance, and it's how it's related to health equity. And so when we look at equity, diversity, and inclusion, what we're thinking about is, again, inclusive excellence, where no matter who you are, whatever the identity you are, your lived experiences, your background, that you can feel completely a part of the organization, and most importantly, also contribute back to the organization as well. Because we know that everyone that is part of our workforce is actually part of a much greater community. And that's where we also live, that's where our patients live, and of course, those are the communities we're a part of and that we serve. But when we think about health equity in general, we know that there's many factors that go into health equity. We have to think about those social, those structural, and those political factors that drive the propensity for someone to be healthy and to have a well-living life or not. And we know a lot of those things are based off of someone's economic stability, their education attainment, the social constructs and the discrimination and racism that they may experience, food security, the neighborhood and physical environment, and yes, healthcare services. But there's no way that we can actually provide strong, equitable healthcare services to our community if we're not upholding principles of equity within the organization. So I say that because as we're all thinking about equity and as we're all thinking about justice, it has to start at home. Because if we don't have it within our organizations, there's no way that we can continue to go and feed into our communities that absolutely deserve nothing but everything in terms of the best. So a little bit more about what we do in terms of my office. Again, my office was established when I became chief earlier in 2020. And again, what we do is execute all the system-wide strategies to strengthen and to advance equity, diversity, and inclusion amongst our staff, patients, and the communities we serve, with the overall mission to create and advance a healthcare system that achieves optimal health and well-being for our staff, patients, and community, with a vision to also be that premier leader of inclusivity, justice, and equity within healthcare. And with really embracing the values of accountability. Everyone's responsible for this work. Service, meaning what we do, we're here for a reason, and we're here to definitely support our patients and the communities that we're part of, that we're from, and that we also provide services to. But doing it in a partnered way, not only within the organization, but partnering directly with community and upholding the principles of excellence at all times. And then also thinking about the courage and embracing the courage in order to do this very hard work and making sure that all that we do, both good and bad, is fully transparent. And so some of the principles that we have been following are actually listed here, and which number one, we made sure to commit and really emphasize that a diverse and an inclusive healthcare workforce actually does result in better care, service, and healthcare outcomes for the diverse patient populations that we serve. And then in addition to that, we also believe that equity, diversity, and inclusion in general, as we know from all of the various different literature from so many different industries, results in greater productivity, innovation, and engagement. But we're taking that a step further. It's not about beliefs anymore. It's about commitments and action, and which we have committed to building those stronger work relationships within our organization and with community in order to provide high quality, equitable healthcare to all the diverse patient populations that we serve and that are part of our city. And then also doing this by intentionally embracing anti-racism, anti-bias, anti-discriminatory principles in order to advance equity and justice for all of our staff and patients. So I want to actually introduce what I call the 5 A's of health equity, diversity, and inclusion performance. My background as well, I have a background in performance improvement, Lean Six Sigma trained, as well as health services research trained. And so when I think about all of these different challenges that we have as healthcare and organizations, as well as thinking about what we need to do to advance equity and justice within our country and within our communities, I tend to think about it from a performance improvement lens. What are the problems? How do we fix it? How do we measure it? What are our key points of success? And how do we continue to go back through the cycle and continue to learn and iterate upon what we're doing? And so the 5 A's of heady performance, which I like to say, are number 1, awareness of racism and bias within the organization and the society, and awareness of where those challenges are that we need to really place our efforts. Number 2, acknowledgement, both past and current transgressions and areas to improve upon as we're thinking about all of these different areas. Number 3, action, and most importantly, being data informed in order to drive that strategic plan towards where our goals are and that vision is. And number 4, accountability, shared leadership, accountability, and ownership throughout the organization. And then 5, achievement with continuous learning and improvement. Now, I don't know how many of you all may be in various different leadership roles to advance diversity, equity, and inclusion. But I can tell you just my own honest opinion is that one of the reasons why sometimes we have not been as effective in this area is because we as large organizations or smaller organizations have had a person in place, but then that is all. And DEI has literally been separated from the rest of the operations and the rest of the strategic planning of the organization. And everything's been placed on one person's shoulders or on one office's shoulders and saying, you all take care of all that type of work. So I hope now that since we're in 2021, that's not the case in many organizations, but we know that historically this work has been very performative in nature, and which then organizations can just say, oh, we're just going to check off the box. We have that person there, but yet that person has not been at the table and they have not valued that person and their insight as much as what they should be. And so that is where that needs to change in order for our organizations to excel to the place where they need to be in order to do the work that we need to do with our patients in our communities. And so one of the things that we have really made sure to enforce is that we believe that equity is an essential principle that is incorporated into every single corner and every single part of the organization. And that is not up to me or my office or my team. It's the responsibility of everyone from the president of the health system to our frontline staff members. And we're doing this in a couple of different ways. Number 1, by building new structures and practices to promote anti-racism, inclusive excellence, and equity for our people internally. Number 2, to improve the clinical experience of our patients through accessibility, cultural humility, and affirming care. And then also by investing in our community through education, service, and advocacy. We've been talking, and Amner was mentioning a lot about advocacy and what we can do. You know, I was going to wait till later on to mention this, but advocacy is truly one of the most important things that all of us should be doing. And so, and especially as we're thinking about how do we best serve our under-resourced communities, which we know, as Abner even mentioned, our social structural determinants of health actually matter a lot more even than sometimes the care that we provide, because we know exactly how all of those things feed into one's outcomes. But we literally have racist laws that still continue to this day and classist laws that still continue to this day that prevent our most under-resourced communities of color from actually receiving the same care that other people receive. Medicaid has set up a 2-tiered system in this country. And let's talk about that. We have a 2-tiered, if not 3-tiered system in this country of saying who gets healthcare and who does not, who gets reimbursed for care and who does not. And that makes zero sense that the communities that are most vulnerable, that oftentimes need healthcare most, that reimbursement for taking care of them is significantly less than other populations. And so that is a clear example, and I saw that somebody mentioned that and put that in from Dr. Batchelor's. It is a clear example of systemic racism and systemic classism when we even look at how our insurance systems are set up. And I also don't know if there's too many any psychiatrists on the call either, but a perfect example is also the IMD waiver, where it started off in the 1960s when Medicaid was actually approved, where Medicaid states that they will not, the federal government will not reimburse any freestanding inpatient mental health hospitals for caring for a patient if they have Medicaid. So there's no reimbursement from the federal government to mental health hospitals if they're caring for somebody that has Medicaid. So that is one of the reasons why we oftentimes do not have mental health services in our lower income communities, because structurally, even the payment models do not support that. So those are some of the different things that we have to see, all of these different policies. We have to see all of these different structures that have existed in our countries from decades and start advocating against them to change them so that we can provide better access and, of course, equitable care to all of our patient populations. So I just also want to show you a little bit in terms of some of these different 6 pillars. We have 6 strategic pillars, and I'm not going to go through all of them, but I'm going to just highlight a couple of them of trying to demonstrate what we're doing in order to promote health equity as well as justice amongst our staff, our patients, and communities. And some of our fiscal year strategic pillars, even from today, is first starting off with our people. Really making sure that, as mentioned, we're increasing awareness of what anti-racism and anti-discrimination really even is in the organization, but also putting in place the new policies and the procedures to directly counteract any of this type of behavior, whether it's internally to each other or whether there's any type of discriminatory behavior towards our patients or those that actually visit us within the organization. But then we're also, when we're thinking about patient experience, too often we have these generalized patient experience surveys, but do we disaggregate all of those different surveys and all the different feedback by race, ethnicity, gender identity, sexual orientation, language, religion, to really see, are we really providing the best patient experience to all of our patients? Are we really humbling ourselves in terms of culture and making sure we're linguistically aligned? And are our patients leaving with the same feelings and sentiments as someone else who may be of a different identity and background? So that's one thing that we're doing, is really not only trying to promote a more culturally and respectful, linguistically aligned clinical environment, but making sure that we have those additional data elements so that we can assess when we do have any variations in experience as well. The other item, quality, safety, and value. According to the Institutes of Medicine, quality is made up of 6 different principles: timeliness, effectiveness, lots of different principles. But one of the other one, the main principle, is that that care has to be equitable. So in order to provide quality care, it has to be equitable. And that's something that for some reason we haven't really dived as much into until recently over the past years, when we start to get away from terms like just looking at disparities and really trying to focus on equity. And so some of the things that we're doing, which I'll describe a little bit more of, is that we have now created new data infrastructures within the system in which we can actually disaggregate that data by, yes, all of the standard demographic features like race, ethnicity, language, gender identity, but also most importantly, thinking about social vulnerability. So really taking a look at the communities that our patients come from in order to see, are there any variations with care, with overall utilization, with readmissions, with satisfaction, you name it. But we've also put into place what we call equity checks, so that throughout various different areas of the organization, we have equity checks built into how we provide care to patients. So it's no longer just in the back of our minds like, oh, is this person receiving equitable care? No, as we're going through and we're checking off, did they receive their medications? Did they receive their appropriate DME? Are there any things that we need to consider for this patient that are unique to them to ensure that they do receive and achieve the most equitable outcomes? And are we making sure our decisions are free of bias and free of any form of discrimination? So we are now equity checks throughout the organization, but also when it comes to our risk management. So if we have a risk, any type of root cause analysis or incident review response, we have a bias check and an equity check that's in there to see if bias or discrimination may have contributed to that adverse outcome. Some additional pieces with strategic operations and growth. We are actually going to become by January an anchor institution, and several of you all may be familiar with a healthcare anchor network, especially if you're from UCSF or UC Davis or Kaiser. UCLA will be doing the same. And the whole idea of this is that it's not enough for us just to provide care within, again, our four walls, within our clinics and our EDs and our hospital. It is our job to be in community with community and think about inclusive hiring, think about inclusive procurement of who are our vendors? Are they minority-owned vendors? Are they women-owned vendors? Are they veteran-owned vendors? And making sure that we're contributing back to the local environment and economy in productive ways. And this also goes hand in hand with many of our environmental justice and sustainability efforts that we're looking at as well, and which we're thinking about how best can we position not only what we do as an organization to actually improve environmental justice, but how can we be with community to set up new structures to make sure that we have climate sustainability and environmental justice, especially within our most under-resourced communities. Financial sustainability is also there. Equity is actually built into this, thinking about our centers of excellence, thinking about our expansion of philanthropic support to support our health equity initiatives. And then last but not least, community service and engagement, optimizing community partnerships as mentioned, but most importantly, what are we doing to increase the pipeline? What are we doing to continue to diversify our workforce? And again, advancing advocacy efforts and coalition building. So due to time, I won't go too much into some of our different achievements, but one of the couple of things that have been very instrumental in terms of our journey has been number one, creating an equity council. So I'm the chair of an equity council of over 30 different leaders from throughout the health system, all the way from the president of the health system to several of our leaders in health equity that are through both our School of Medicine as well as our health system. We meet every single month to oversee all of the heady initiatives that are going on to ensure that we're on track and to deal with any challenges that come up. In addition, already we have trained over 900 leaders in equity, diversity, and inclusion and anti-racism core principles, and have held many different town halls to discuss where are the issues, where are the challenges, where do we need to go. We've also made sure to develop many new policies, especially addressing things such as patient discriminatory conduct towards the workforce, which definitely can add a burden and also cause reverse inappropriate behaviors back to our patients. And we're also tracking all of these various different incidents of racism, discrimination, and bias. And we put in place a huge response infrastructure so that if a patient has a concern, staff member has a concern, no matter who it is, that we have a response within 24 hours to investigate it and to deal with it from the very beginning. And as mentioned with quality and patient safety, we have several different dashboards that we're tracking our organizational performance in all of the various different demographics, characteristics, but also other social vulnerability characteristics. And as Abner was mentioning, our data collection across the country is very poor. And that's one of the things that we're doing even internally. We are in the process of redesigning even how we collect our race, our ethnicity, as well as our language data and religion, and which most importantly, the patients need to self-identify who they are. It is not our job, and it's not appropriate for us to make assumptions about our patients. So we have created a brand new way, more patient and person-centered approach to collect not only race, ethnicity, but all of our sexual orientation, gender identity, as well as religion, language, and even soon to be technology access data so that we can appropriately store it and do the appropriate evaluations in order to see if there's any variations in our care and outcome, and we can address it right then and there. In terms of community, there's a lot of things that UCLA has also been doing in terms of, we were one of the main partners here in Southern California with providing medical services to unaccompanied minors that came up from our U.S. Customs and Border Protection facilities. So we provided all of the medical care, all of the psychological and psychiatric assistance to the children that came up, and also helped to reunite them with their families as well. As mentioned, we've been doing a lot of focus on environmental justice. One of the key social structural determinants of health is sometimes too often overlooked. And also being in the community during the time with the pandemic of actually providing meals and other types of resources to many of our under-resourced communities throughout LA. So I want to get into a few other things of the lessons learned. But one thing that I think is also important is thinking beyond, again, our walls and how we can be creative. And one thing that we've been doing is actually launching our new homeless healthcare collaborative. We are actually launching a fleet of vans that are literally licensed by California Department of Public Health. So they're clinics on wheels in order to meet our patients where they are. We know that there's a huge increase even of people experiencing homelessness, not only in Los Angeles, but throughout the state. And one of the things that we will be deploying is these vans fully equipped with all various different medical equipment, vaccines, medications, in order to provide care directly to patients in the community, on the streets, in their encampments, in temporary shelters, in tiny homes, as well as safe parking areas. And the reason why we're doing this is because we know that people experiencing homelessness is one of the most vulnerable populations that are there. And it's not only about providing really good health care, but it's also making sure that we do those warm transitions to social services, such as trying to get them into permanent housing and also helping them with all of the other economic services that they need. So that's something that's near and dear to my heart and near and dear to our organization right now. And we'll be launching that also in winter. So to sum up, some quick lessons learned: seek and inspire diverse voices, center those who have been harmed. Data must drive strategy, wear a raincoat, and be bold and courageous. These are just some of the lessons that I learned while being in this role. And then when thinking about seeking and inspiring diverse voices, one of the most important things that I've learned, definitely trying to establish a very robust system in order to drive health equity, diversity, inclusion within an organization and beyond, is that we really have to make sure that we proactively listen to and empower the voices of various different perspectives. That's too often, we've only listened to voices at the top. And when doing this work, it's important to hear everyone and make sure that we understand which lens that they're looking through. And then also part of that, setting a vision and a goal for the organization. In addition, one of the key recommendations I have for anyone that's doing this work is to make sure to drive momentum and change using narratives and visuals. I think one of the most key factors that drove us in the performance that we were able to achieve in such a short time is my marketing and communications team. We have an entire set of people that are devoted to really ensuring people understand the principles of equity and racial justice, and also what it means and what it does not mean. And that has made a significant difference. And then also ensuring that there's shared ownership and accountability to drive EDI. The next thing is also making sure to center those who have been harmed. In this work, we tend to like to point fingers at the people that are doing the harm and not actually protecting the people that have been harmed. In order for all of this work to be successful, whether it's organizational or directly in community to serving the patients we serve, we have to make sure to focus on those that have been historically and recently felt all of the various different transgressions. And in order to do that, we have to have that immediate acknowledgement of the harm and put in place the support to reinforce positive actions and upstander behaviors. Now, I'm a big data person in every single way, and data has to drive strategy. Too often when doing the work, we have not utilized some of our performance improvement methodologies nor data to say health equity, it's not just some fuzzy area. Health equity truly is about outcomes, and health equity truly can be measured every step of the way. So definitely make sure to use the data to define goals and create strategies in order to mitigate any forms of equity, diversity, and inclusion issues. And equity, again, must be incorporated into all operational metrics and incentives, and really looking at everything from an equity lens to see who may be unintentionally impacted by the policies, by the procedures, or the other practices of the organization. And then this work is heavy, very heavy. And so it's really important when you are leading this or part of this work, and just to know that you have to wear a raincoat and let things slide off of you. Critique is always going to be common and expected, but that's part of driving change. And especially when you're up against certain structures that have been in place for a long time to advantage and disadvantage others, whether it's intentionally or unintentionally. And then I always say to everyone, give yourself grace and practice self-care. And then last but not least, this is my spirit animal, a lioness, but be bold and be courageous in every single way. And which this is such challenging work. You have to be able to have that strength to push through and say what we're doing is the work that we're doing because it's the right work to do. And it's going to be hard and it's not going to be easy, but we have to do it to make sure we have a much better future. And so thank you. I may have gone over time, so sorry about that, but thank you all so much for letting me share some of these thoughts.
Thank you very much for everything. Great presentation. So we will now turn it over to Joa. Do I see you there?
Yes. Can you see my screen now?
Yes.
All right. Well, good afternoon, everyone. And thank you to my amazing panelists that have shared some great work that they're doing. Abner and Dr. Medell, it was just a pleasure to hear the work that they're doing, and want to talk with you a little bit about what I'm doing and what I've been doing. My name is Audra Jones. I am the African American Infant and Maternal Mortality Outreach and Engagement Director with LA County Department of Public Health. And so the first slide you see is one in which we share through our Black Infants and Families Los Angeles webpage, where we are highlighting and encouraging the importance of every woman receiving support, being surrounded in love, and being heard in their journey through pregnancy and childbirth. And so some of my work started prior to where I am with the Department of Public Health. I was doing some work with the Department of Health Services Whole Person Care. And in that work, we had 6 issues of focus, and one of which it was to address, either create a community action team surrounded one of those issues of focus, either homelessness, substance abuse, re-entry, high-risk maternal, and high-risk mental health issues, or those who did not have a primary medical home, which we call our transitions of care, or they didn't have a PCP. And so my background is in reproductive health and maternal and infant health. I was the first community health worker for the first Black infant health program in Los Angeles, which was Great Beginnings for Black Babies. And at the time, it was Inglewood Healthy Mothers and Babies as well. And then I was their first perinatal health educator. So I spent several years in my role doing work within public health and health services, as well being a longtime member and advocate and now board champion with Black Women for Wellness, which I've done for the past 25 years. And so what I want to do is kind of take you on a journey in the work that I did as the visionary for the first African American Infant and Maternal Mortality Community Action Team in South LA, South Bay, which our acronym we call SLASB AIM-CAT. And I'll talk more about where we are with these community action teams and what we've done. And so what I'll be sharing to you is how we did this work and how I came together to bring a number of community-based organizations, clinicians, midwives, doulas, faith-based leaders, community-based organizations, directors and members of their staff, as well as everyday lay folk, to come together around reducing AIM and around the impact of AIM, and really looking at and highlighting what has happened for 400 years to the descendants of the African slave here in America, and how that has impacted our lives and our birthing opportunities, as well as the lives of our infants. And so in this work that I'm doing, I just added this slide in here, is more like coalition leadership, where I'm really, it's a movement. We're doing a process movement where leading individuals within our community, really kind of guiding them, engaging our community stakeholders, those that are most impacted, that have a voice and can share, what it is that has happened to them and how they need to be heard and how they are best served. So some of that work, I talk about that and how we started in this work, is I would share with folks that would say, Black folks don't come out for care. And one of the things I talked about is that, for any of us on this line, I would dare say, if you're going to some place and you're not receiving your best service or care, maybe you're going to a restaurant and maybe you're trying something out for the first time and you have horrible service there, and you decide you're not going to come back. Or maybe you try to give them a try again and you receive the same type of situation. And so one of the conversations I have, or what I bring up, is why would someone continue to go to a place where they're being abused or treated harmfully and continue to go back? I dare say you would. I know I don't. I don't give my money to people who don't appreciate that, because it is of value to me. And, if I'm going somewhere and I want to, appreciate the service you offer, whether it's food, whether it's clothing, whatever it may be, a business of any type, I want to be able to share with others the great work that you're doing. And so that's the same for us. And even especially we need to look at the fact that when you're talking about medical care, we're putting ourselves in the most vulnerable situation, especially as a woman. And I feel for anyone, as you lay there bare on a table to receive medical care, I'm entrusting myself to you. I'm entrusting that a physician or clinician is skilled in the work that they're doing, and they're not going to treat me any differently based upon the color of my skin. So what I was able to do was call together folks that I worked with for over 20 years, folks that are new to the work, and come together over a shared interest. Our shared interest is to ensure that Black women have a great pregnancy and birth outcome and a journey that anybody else is receiving, that is without racism, without implicit bias, and without harm. And within that, we also have the opportunity to develop other leaders within the work. And so that's some of what we've been doing, and I'll just go into a little bit more depth. The scope of our work is to reduce Black infant and maternal mortality. What we're doing in this community action team, the establishment of such, was to look at ways that we could identify the gaps in services and resources in our communities, and also create strategies from those with the lived experience, whether they were of our older community, our elders that we call seasoned folks, who had experiences when they were given children, or those who are, deciding that they want to at some point have a family, or those who have already had children and have had, good or bad experiences, and what would they do to improve or encourage better outcomes. We also, this was one of the things that was important to me, was that for the time that I had been in the work, throughout our county, the rates for infant mortality always ranged somewhere in between 10 to 12%. And we had never saw a 5 to 6%. So we had never reached a halfway point. And so to me, that was very critical, being one that I had also worked in public health for the Black Infant Health Program as a contract manager, managing some of the organizations that I had previously worked for, and have found that we had not really done our in-depth work to honor those organizations, and what they were sharing was a need. We would say, from public health perspective, here's the money that we have. This is your scope of work. This is what you're supposed to accomplish. And generally, it was accomplish a lot with a very little. And so, yes, as Black folks, we've been able to make $1 out of 15 cents, but why should we when we're talking about saving lives? And so I wanted to see something different, and I had not been afforded that opportunity when I was working there from the early 2000s until I, was switched off of the Black Infant Health Program around 2008 or so. And so this was the perfect opportunity to see if my community felt the need and strong about us going forth and partnering with the health agency, which was Department of Public Health, Mental Health, and Health Services, to really address this. And we, one of the folks I met with was with Kaiser, and I've had a good relationship with a couple of the community benefits managers over there. And with Kaiser, they helped us to allow us to have our first meeting at the site at Baldwin Hills. And so when I have been out in the field, whoever I met, male, female, father, son, uncle, brother, I didn't care who you were, clinician or not, I was letting you know, listen, we're coming together to see if the need is here, and if we want to meet the need of establishing a community action team. Our first meeting at Kaiser Baldwin Hills, we had over 100 folks there. We had to turn some people away. And so in that was the beginning of the establishment of our community collaborative partnership. Within that time frame, we were able to, at our first 2 meetings, we had one in October, and then November, we start the beginning of establishing a vision and mission. some of which was where the community said we want Black-led leadership. We also want not a top-down reporting structure, and we want a real partnership to make this happen. And so we have been meeting, hold on one second, I'm sorry, I'm going backwards and not forward. We have been meeting since October of 2018. We're going into our 3rd year. And how this, when we presented the information, we presented the facts. The fact of the matter is, Black infants are dying within the 1st year of life. And CDC reports we lose approximately 4,000 Black babies nationally within their 1st year of life. And data supported from the county that, LA County data supported that we were losing Black babies at the rate of 2 to 3 times the rate of white babies in LA County. Some folks have even shown that it was 3 to 4 times that. We also presented the facts around maternal mortality. And I've heard some of my colleagues, both Abner and Dr. Medill, talk about data. The concern I have, and data is very valid and important, but I need, you all to hear and folks to understand that we are more than our data. And so, this has been critical and important to us to see young Black women dying. And I'll talk about some of the folks that we have met along the way who have lost their daughters, who have lost their sisters, who have lost their infants. But one of the things is that now with the PMSS data that just came out from California a few weeks ago, we have been sharing that in California, Black women are dying at 3 to 4 times the rate of white women, when in fact, it looks like from the data that had not been collected for so many years, that we were dying at 6 times the rate of white women. And that is just showing data up until 2016. So I'm really concerned about what will happen when we find data even after this pandemic. And prayerfully, hopefully, with all the work that we've been doing, we'll find that the data is even going down, or that some of our work has been effective. And I'll talk a little bit more about the work that we've been doing around that. So why do we first start with South LA, South Bay? Because we had data that showed that the county is broken down into 8 service planning areas. And the 3 areas that had the highest rates were SPA 1, which is Antelope Valley, Palmdale, and SPA 6 and 8. So we found that nearly 3 in every 5 African Americans live in SPA 6 and 8. 2/3 of African American babies live in SPA 6 and 8, and 2/3 of those infants died in those same service planning areas. Also, nearly a half of the maternal deaths between 2005 and 15 were mothers who lived in SPA 6 and 8. Now, what I'll say to you about that too is that initially when I started this, the Center for Health Equity and Dr. Ferrer, they were focused on Black infant mortality. And my focus with whole person care and DHS was maternal. And I said, one thing we cannot do, I know you have the African American infant mortality work, but we will not establish a community action team or do this work without identifying that we are going to address the needs of those moms who are carrying those infants as well. So that's why we had the establishment of AIM with the 2 M's. And it was also a time period where Dr. Ferrer, other social scientists, data was being shown that racism was basically one of the leading causes of this vast disparity for Black folks. And even though we have lower rates, it's sad that across the nation, there are much higher rates. The other thing that was happening was that when I first started in the work, there was a lot of victim blaming and shaming, and there was a lot of emphasis put on what Black women were doing. And I was involved in some of that too by what we were being taught and shared in the work as we were being educated, because yes, we did have a very high incidence of, drug and alcohol, substance use in our community. And we could, that would be a whole nother meeting to talk about the introduction of drugs into our communities and the variation between, opioid addiction and cocaine and crack in our communities. But at any rate, we were able to look at how imperative it was to stop the victim blaming and shaming and acknowledge that racism is a huge issue and a problem. Not just racism, but the biases attached with that. And so even though we're lower here, like New York is 11 times higher, or Black women are dying, Texas is about the same, we still all have a lot of work to do. So in presenting this, I just want to share with you, we stand products and services delivered to our community, but it's really our entire work that we're doing within the community action team, where the county is offering the capacity and technical support. So when I started this, we had no money. We had no one supporting or providing any funding towards. We just had some staff that were in each department that were, willing to work and interested in this. And then we had community members that we were bringing in. And we were looking at ways that, how would we really fund this work? We wanted to also, respect the intellectual property of those who are involved in the work, and also be able to support them by providing funds or stipends to those who are participating in our community action team. So we looked at some and we were able to get funded. I'll tell you a little more about that. We also offer free training to those who are participating. So they were able to get some facilitation and collaboration training that we offer to several community members, including directors of nonprofit organizations. In this work, Whole Person Care first started to support there was one pilot, Dr. Pooja's on here, and she worked with the HealthNet team. So HealthNet had started a pilot to provide doula services to their African-American clients. And then at the same time, Whole Person Care funded for the Department of Public Health to start their doula pilot program, running simultaneously. HealthNet has stopped, but LA County has been providing for the last year and a half, almost 2 years, free doula services to African-American women in LA County that are pregnant and parenting, identify as Black, and those services are provided by 10 African-American doulas. I work with 3 other colleagues to develop a doula board motion through our fellowship with the Women's Policy Institute, which was adapted by our Board of Supervisors, Hilda Solis, and our former supervisor, Mark Ridley Thomas, in January of 2020 with unanimous vote by the other supervisors. At the same time, Dr. Melissa Franklin, who manages our communication and leads our steering committee, created the Black Infants and Families website, which we wanted to keep separate from county and First Five so that it would not have as many controls and we would be able to share without it being a problem for any of the systems. Let me go to the next slide. And so I talked to you about what we were doing, but a lot of this work is about racial health equity initiative. And what we wanted to do was, talk about the importance of our collaborative, also look at being transparent and especially around funds, because it becomes a problem when we aren't transparent about how money is moving, how money is coming. And that has been a real work in progress. I could share more with you about it. And then how important it is to call racism out by name and really continue to address it and not ignore it. And as I share with you, when we started these community action teams, we were just trying to see, what could we talk about? How could we establish and identify gaps in services and resources? Went out into the community, decided that we would have bi-monthly meetings with our CAP members involved, and also with the structure of the 5 work groups. Right now, we have reached a listserv of about 700 individuals. And so this is just some of the flyers and work that we've done. We established in that a Black Daddy Dialogue, which was created by one of the brothers I invited to this group work, LaHenry Solomon, and it's created for Black men, by Black men to, introduce them to AIM and also work with them through the pregnancy journey, and for them to understand how critical it was to support their wives, spouses, girlfriends, aunts, cousins, sisters in this journey. Also, we established when COVID hit, we were having all these meetings anymore. So one of the things we also offer, we pivoted to virtual for everything, and I coined the term virtuality, where we're offering every month a topic around African American infant and maternal mortality. And so we have these virtual offerings that's ran by one of our work groups. I'm not going to go through all of these flyers. This shows you some of the work. We also were very instrumental in the passing of SB 464. So you see us there with our current supervisor, Holly Mitchell, who was the senator at the time. We took, along with Black Women for Wellness, a cohort of women from Fresno, LA, and Sacramento to lobby for this work. And so what our AIM initiative in LA County looks like now is it's been a collective. We now have 4 community action teams and a steering committee. We are meeting monthly with our work groups for the community action teams. Our steering committee meets monthly. That is a higher level group of executive directors. We also have within each CAT a planning team. And then we have First Five and LA County Department of Public Health that pretty much lead the effort around the initiative and also the direction of funding and guidance. And so we call ourselves as a collaborative of collaboratives. Our goal is to eliminate racism and reduce the effects of racism on Black women. We also have partnered with Department of Public Health in their 5-year equity initiative plan to reduce the Black-white infant mortality gap by 30%. This is somewhat of what we're looking like now. We have a Cherished Futures hospital collaborative that we've helped to support and fund some of their work. I'd have to go more in depth with you because I want to make sure I honor our time here and not go over my time either. But this is kind of another picture of it. We have, each of these groups has really expanded the policy and advocacy work here that started in South LA, South Bay has now expanded to be focused countywide. So we're moving that work group out of one section into just focus on the whole entire community action team. Excuse my alarm, I wanted to make sure I'm safe. We have a funder circle. Those are each being established in each community action team. So you see now we have Antelope Valley, San Fernando Valley, San Gabriel Valley. And then, as I said in the beginning, the one for South LA, South Bay. I want to talk more about the structure. I'm going to go over to a little bit about what could happen in this work and why, you know, it's pivotal for us, like the risks and uncertainties and objections that could happen that could, you know, put a stop or a little hold on our coalition. But we're looking at ways to fund right now strategic planning, right now more training to the community. We've also had doing the work to increase the Black maternal health workforce, which is critical for Black women. We're working on SB 65, which has been at the governor's desk. And some of the things that we have seen too that have, really put a little uncertainty or risk in our work is like divergent ideas about which way do we head, what should we focus on. And so we're looking at how do we identify that in a like collective impact type of way, because we know that when you bring the community together, you want to make sure you hear all of the voices, those that have been in the work, those that are new to the work, the county and the community, making sure that everyone is heard and their work received. Because a lot of this, we realize could have been avoided if we just learned to hear people, listen to them, and also honor and respect their issues and their requests and needs. And then staff reassignment, that happens, people move on, and then we had a lot of reassignment during COVID, but we still have been finding great success in our work. If we don't achieve that maternal mortality and the infant mortality rate reduction, that would really be an issue for us as well. And then the community complete reliance on government. You all know we just have a history. It's 400 years plus of history where there is medical mistrust, where there is mistrust in the system. Just for many of us, even like as I hear about the diversity, equity, and inclusion, one critical piece is that we want folks to truly honor those letters that came about last June of 2020. Floyd, Sister Breonna Taylor, Brother Ahmaud Arbery, and so many more. We want those words on paper to really match up. And if we don't receive that, then what was really the point of, creating all of these, equity initiatives and inclusion and diversity if we're really not going to be act upon it, and if we don't really have allies that we can trust and honor what they say. And so right now we're looking at sustainability of our community action teams. How do we partner with other medical institutions? We've had great partnership with, like I said, Kaiser. Kaiser was able to fund about 4 or 5 of our organizations in 2020 for them to continue to do the work. We provided grant training through the Grantsmanship Training Center. And we're just continuing to look at ways, even right now, to expand doula services, our midwifery in Antelope Valley, to address the desert of care there, the absence of much needed care. And how do we build success well beyond? So since this has been going on, and the Black-white infant mortality gap first started being recorded in the 1850s, which we're almost 200 years into the recording of such, we should be able to be funded and supported in this effort well beyond 5 years, well beyond 10 years, because it's going to take some time and effort to really have some effective change. And so Black-led leadership, I think that's critical and important. I think Brother Abner mentioned it. We have to get out of this place of feeling uncomfortable about Black folks leading issues that have impacted them the most. And we have to be able to trust our non-Black allies, that they're going to support that and respect our intellectual property and ideas, properly cite us. Don't come in to, get your degrees and get more credits and write more books off the backs of Black folks. It's been done long enough. And we just want to be honored and respected, because we too know, and we still have some knowledge around this work. Our foremothers were critical, as they were the midwives for the master's children of the slave owners. They were the granny midwives and wet nurses. They sacrificed their children and families for such. And so we are still recovering, are working to recover from that trauma while being re-traumatized again and again. If a couple weeks into looking at what happened with the Haitian immigrants was not a reminder, I don't know what else we could get to continually be traumatized in this area. So some of these pictures I put up, some of the beautiful young women who have lost their lives while giving birth. One of which at the top, I remember Amber Isaac had shared via her Twitter or her social media page that she couldn't wait to get through her experience and have her baby in New York at this medical center, and she did not survive. Her child did, and as a result, her partner is now advocating around maternal mortality. And one of the issues she was going through telehealth, but a lot of her medical needs were not being met because of her conditions that should have been. She probably should have really been brought in to be seen. Also, the one in the middle, LaShondra Hazard, had been at a facility in Rhode Island, I believe, and she was posting on her social media page, "I'm literally in pain. I'm here. I feel like I'm dying. They're saying there's nothing wrong. I'm about 3 months pregnant." And folks were asking her what was happening, what was going on. And they said, "Oh, no, there's nothing wrong with you. The pain you're experiencing is normal." By that evening, her and her unborn fetus, had passed away. Most of you may know about Charles Johnson, who's a strong advocate after the loss of his wife at Cedars-Sinai. And this list goes on and on. Catherine Terry was a young 24-year-old mother in January of 2020 who passed after being given some medication at the hospital that caused her to go into cardiac arrest and seizure. And she passed, and her infant is here without their mother. So I just want to share this all with you, but our goal is to continue to have great partners that will join in the fight with us to save Black moms and babies. And that's really it. I thank you for allowing me to be here and share some of the work we're doing to really impact and change lives.
Thank you so much for sharing. All of you, thank you. This is great work. It's important work. Ooh, let me take a deep breath after that one. And so we really appreciate all of your time here. We do have a few minutes for a couple questions. Same, raise your hand, use the little icon to raise your hand. Renee, if you can help, just find them because we have so many. And then we can go ahead and have that dialogue.
Abner, I'll ask a question as we're waiting for people to get warmed up. So there were a couple like more discrete questions about your presentation in the chat. And I don't know if you have the answers to them, but one of them was around the slide you showed about patients under age 65 having so many providers. Can you provide some insight into why that might be?
Some of the responses in the chat were accurate. It's just that between, we live in a very mobile society, people moving constantly, even within a city. Also, even when they don't move, they get reassigned. Like a lot of plans will change the network. And you could be in the same place and over a 4 or 5 year period have, because of network changes. So the reasons in the chat are very much the reasons. And if you have any kinds of specialty care, then that adds, a whole host of additional providers. And so it's I'd ask each of you to think back over your lifespan, how many providers you've got, if you include, because you tend to forget, like if it's a specialty you forget, I did go to, a certain kind of specialist at a certain point. If you really think about it, or take a look at your own, your own personal electronic health record, but you probably don't have it because it's not all in one place. You'll see it's pretty easy to see how it adds up pretty quick. And don't forget to include college. And before that, once you include it all, it's just, if you start to think about it, the number just expands and expands. So yeah, so the reasons that people gave are pretty much, those are the reasons. But it just points to the need for, we've got to move to a healthcare system where the data belongs to the healthcare consumer. It's their information. We ought to figure out a way to make it easy for them to have it in one place. And then, yes, you got to have protections, but they should be able to share it with who they want to share it with. And so unfortunately, or maybe I shouldn't say unfortunately, it's just a reality. Healthcare data is very valuable. And the way our healthcare system is structured, there are entire parts of the healthcare system that the significant part of their value and their sort of a moat around their business is the data they have about their patients or their members, and they are not going to be easily, they don't want to give it up.
Thank you. Maria, do we want to, oh, Jerry raised his hand. Great. Jerry, go for it.
Excellent. Yeah, I'm not shy. First of all, excellent presentation. Thank you all for just incredibly powerful presentations. This is a question for Dr. Briggs-Mallinson, if I pronounced that correctly, about leadership within your organization. Have you all had those difficult conversations about board leadership, maybe management leadership within the organization, and maybe any insights on how that's going?
Well, thank you for that question. And the answer is yes. So our initiatives started with our president. So even before my position was created, she said, we have to make a change. And so she actually started it and actually had mandates for all of her senior executives in terms of what they needed to do to start building the structure to advance health equity, diversity, and inclusion. And we had a group of us as Black leaders that actually had already formed almost as a grassroots group to provide each other support after the death of George Floyd and everything that was going on with our social movement. So we needed to be there for support of one another, but then also we structured ourselves to be that strategic partner as well with all of the executive leadership. And that's how several different things went into play. But we have actually put in place many different processes now in order to ensure that we are moving towards having appropriate representation all the way from our executive leadership to our mid-level leadership to our board composition. And we're doing that in terms of our searches. We require that there is at least 25% underrepresented minorities and overall 33 BIPOC people on each one of our search committees. And in addition, a member of the Equity Council has to be on there. It is required that there's implicit bias of anybody who is hiring, so that they think about all their blind spots before going in. In terms of we've done that already, and we have lots of other structures to make the processes very objective. And we're tracking all of our numbers as well. So we know our representation right now and where our representation as it correlates to LA County. And those are some of our goals. And then even with our boards, I've actually gone and had conversations with our boards in terms of inclusivity and the importance of our boards to represent the communities that we're part of and the patients that we serve. So we've had all those different conversations about everything from our lack of diversity in places, how we can expand equitable access, and to institutional racism and how we're going to deal with it.
Thank you. So I don't see any more questions. Maria, it's 2:05. That's sort of our time to go to the small groups. Should we bring that up so you can talk about that?
Absolutely. So thank you everyone again for participating and for being so open, with these topics. So we'll go through, again, we're going to go into our breakout sessions. These are really, really valuable and important, but we wanted to go over the group agreements and then also go over the questions with you. So first, remember to participate. So, make sure that you're contributing to the conversation. Speak from your own experience, so using I statements, and come with an open mind, actively listen to others, ask questions so that we can better understand other people's perspectives. And then remember, above all, this is confidential. So share your learnings, keep names and individual stories in that space or in this space. That would be your group agreements. And then we'll go through the guide, Renee. So the guide for the group sessions. So introduction, 5 minutes, 1 minute per person. I am going to ask if we can have a timekeeper in the group. I shared with Renee, I am such an E and I can talk forever. So, but then we have, of course, our I's, and we have to make sure that we allow space. And, sometimes us E's can just go on. We enjoy it. Anyway, so 5 minute introductions, 1 minute per person. Please have a timekeeper. So your name, your cohort, where you work, one key takeaway from this session. Again, identify reporter and timekeeper, someone who's going to share a short summary aloud or via the chat when we return to the larger group. And then timekeeper, really important, keep the 5 minute per person. Let's see, questions to consider. And these questions are going to go in the chat, by the way, so you can either take a picture and or they'll go in the chat. But questions to consider in your groups is, what about this session inspired you? How do you see yourself leading this change or having this work becoming part of, becoming part of how you lead? What similar experiences of success or failure have you had, and what have you learned? And then moving forward, how will you support the well-being of those doing this work? So with that, Renee, if you can go ahead and again, we're going to do a 5 to 10 minute regroup after the share. So regroup and share. So Renee, if you can go ahead and split us up, that would be fantastic. Thank you, everyone.
So you should, Miley's splitting it. Oh, Miley, you going to speak?
Yeah, sorry, just a moment. Some people dropped off the call, so I'm quickly reshifting the breakout groups so that we have more even numbers. Just give me.
It must have been the part where I said share. And just as a reminder, also, our panelists will be going into the different groups to be able to answer some of those questions and also provide some additional dialogue. So, really, really exciting. I see more people dropping off. Listen, if you don't want to share, it's okay. But we would like for this to be a dialogue.
All right, I'm going to open up all the breakout rooms.
Thank you. If I'll have somebody raise their hand and see who'd like to share. I don't see any hands, Renee, do you? Wait, let me put my
I
glasses
don't,
on.
and I'm shocked for how
Well,
talkative this group is. We can volunteer some people.
we
if nobody
can.
wants
I
to
think
share.
Himal would like to share.
That's so mean. Oh my. Maria and I were in the same group.
You're welcome.
We had a really wonderful discussion and learned more about Joa's work and found inspiration in it. So we learned a bit about SB 65 in terms of some additional emphasis on midwifery, on improving sort of reimbursement for doula-based services. And we also shared a bit about our perspectives as individuals in healthcare, and also as family members and participants in the healthcare system ourselves, and just sort of bonded on the experience of it being just a really hard place to be on the other side and be a patient or be a family member, and all the challenges that come up, especially I think, for women, for people of color, for people with disabilities. So reflected quite a bit on that. And then both, I think we had a sort of shared a collection of feeling like there is so much inequity and there's a lot of effort, and that's hopeful, but it also feels like, oh, it's just not enough. Like we're not moving the needle quick enough. And so that is, I think, a shared struggle that people commented on. I'll stop with that. Maria and others, please feel free to add in.
David?
See, David is raising his actual hand.
I wanted to, yeah, it was an actual hand. I wanted to volunteer because I didn't want to be voluntold. I wanted my own locus of control. Thank you very much. We talked about many things, but I think one of the things that kind of resonated is something actually that Alice had indicated this morning, is not to confuse activity with I'm going to misquote her now. Activity with progress, activity with something to that regard, right? And so
activity with action, I think it was, right?
Activity with action, right? And
yeah.
So to really think about similar to what Hamel just had indicated, like what are some of the, how can we ensure that we're getting progress with some of the items that we're looking to do? How can we really tie this to some of the, and really kind of shared struggles of folks really struggling on how to do that, how to operationalize that, from the HEDIS measures to other quality indication measures to network management when you're trying to start at what feels like a really low level to kind of move up. But I don't think we collectively determine this. So please, my colleagues that were with me, please correct me. But I think one of the themes that I kind of sense kind of going is we need to keep having the conversations and keep trying to be able to move it forward, and being able to listen and not presume that we have the answers when we come in, but not be afraid to propose ideas and allow ourselves to be corrected.
I totally agree, David, with what you said from our small group. And I would just add one more point, which is what really stood out for me was an example Laura Miller shared about what Alameda Network has already done to close some of those disparity gaps, making it an incentive, as was suggested by, I think it was Abner, that we need the data and we have these incentive programs, and we can link that to closing disparity gaps. So I was really inspired by what you shared, Laura.
Another group that has something that they want to echo or different that they want to elevate to everyone else? Laura and Kelly, I'm looking at you.
Betsy raised her hand.
Okay.
Oh, Betsy did. Okay, great.
I'll raise my
Betsy.
hand, and I think we lost Alex. I had Lucy and Alex on my team, and we had great pleasure having Medell as our VIP speaker presenter facilitating our session. And I think one of the questions we did ask Medell is, we were so impressed how she kind of built the entire health equity in the fabric of UCLA Health. But some of our organizations still looking for the business case for any type of activity or action to address health equity. And then she actually shared with us their approach is using a very comprehensive dashboard that the data to show the disparity, but with the premises, what is the right thing to do? Not so much what is the business case behind our actions. So that was one takeaway, is to be able to communicate in that kind of balanced scorecard approach, having that dashboard. And she has inward facing and outward facing dashboard that communicate the right message and actually able to drill down, take action. So in order for us to take meaningful action, is really, we have to dive into that level of detail. And I want to turn over to Lucy. Anything else to add? I believe she was here. Lucy.
Let me think. I think that was most, we had just commented amongst our group that how there was a lot of letters or statements put out that said nice things, but didn't actually do anything. My organization, Adventist Health, was, one of those culprits as well. And I think Alex commented that his organization was kind of slow to drag their feet. In Orange County, where Betsy was at, there was even more so for a variety of reasons. But I think I'm getting either to the age or perhaps my patience is trim that words are meaningless unless you actually do something behind them. So.
I'm just finishing up a session in a conference. Can I just call you? I'll call you.
Thank you everyone for sharing so far. We have a couple more minutes, Renee, or?
Sure.
Okay. All right. So I know you were looking at Laura and Kelly. Hi. But if anybody else, Renee Ballin asked you or told you to share. If anybody else would like to share, please.
We were with David and Deirdre, and they were so eloquent. Yeah.
That is
And I
nothing.
think part of it is that I just love
Lately.
seeing that there's like the two of you in a room together.
This is a watch party.
Right.
What you don't know is that they're both knitting, and they're both knitting on the opposite sides of the same Afghan.
And I needed to know that because that's amazing.
You get the work done twice as fast.
Exactly.
Seriously.
Efficiencies, got to find them where you can.
Strength in numbers.
Our group, Abner Mason joined us late in our group, and we really talked about the open record, and all of our the people there were three of us that had some degree of open recordness, but not to the extent that Abner had described, but he really kind of opened our heads about it. And you can write things that can make the patient, where it's plain spoken. And all of us have to keep doing that because we're so used to abbreviations and medical talk. And it was the health consumer should be able to look at everything that belongs to he or she, him or her. All right. I think there are other parts of it were very good as well. We talked about all the speakers and the importance of doulas and the importance of support for all the events, especially for minority people who don't trust the system.
You know, every time you all speak, you send my mind spinning and want to ask a bunch of questions. But this is not about me talking, so I have to reserve those. I do want to ask if nobody else is ready to share yet. And I know we do have a break coming up, so I don't want to cut into your break. But Michael, I did see Michael Changaris. I did see that you had quite a few questions about how do we support the doula initiative in the community. And I know that some of that was answered, but I want to make sure that one, I call out, you know, definitely the community is vital and important in helping to support any initiative. We talked about homelessness as well and so forth, but I wanted to give you, Michael, an opportunity in case there were additional questions that you may have that maybe we can answer as a collective.
So two quick ones would be, one is that it seems like this law is moving forward. Is there anything that CHCF could do to make sure that we put our weight behind having community voices at the table? That seems like one that feels answered, but maybe there is something that somebody creative here could come up with. And the other one is in our local communities who may be working on Black infant mortality and addressing some of the systemic impacts of racism, we may not have as clean and access to doulas or such empowered and powerful leadership. What can we do to bring some of those things to our systems?
I guess I'm on the seat. One of the things is definitely, if you don't know about SB 65, which is the California Omnibus bill, there is still time to sign on to that. It's at the governor's desk. I don't know that he's signed it yet because we haven't heard the hip hip hooray. So there's no party going on just yet. So that's one way. There's also some conversations with the California Department of Health regarding the Medi-Cal doula expansion bill, right? Because this would cover, the Omnibus bill adds to the coverage of doula services for all who have Medi-Cal. And so it would be great to get involved in some of those conversations and learn more about them. I can share them as they come up with Renee and the team so that she can share broadly with you all. You know, our community action teams, if you don't have in your community or you know something that is centered around African-American infant and maternal mortality, any organization, Black infant health programs, they're throughout the state of California. Get in touch with the Black infant health programs because some of those folks are in these conversations as well. Also with the healthcare plans, talking with the healthcare plans to ask them why can't they get behind and support doula care, because it's for advocacy, right? And building relationships between the medical professions, between doctors, nurses, and the doulas, because there's some, you know, we want it to be a partnership, not a, you know, us against them type of relationship. Like I shared in the other group, I was already a perinatal health educator, so becoming a doula to support the other doulas is what I did recently. And we're offering, if you can get in even to support of training for, you know, culturally relevant doulas, right? You have to look at it based upon each culture and each race to provide that type of training and expertise and experience, because we know we've been doing it, right? And there's some other, we were talking about it today, Black Women for Wellness is having their conference next week on the 9th, but they had a pre-conference conversation with some of the reproductive health, you know, visionaries and leads like Loretta Ross from Sister Song and Dazon and those folks, and a nurse midwife, Tanya Komet. And, you know, the conversation is around what we have been doing in the past and what we can do now. So to get with the organizations that are doing the work and highlighting and support those doula organizations, National Black Doula Association, and provide trainings, we could do more of that, to provide trainings. And, you know, make sure we've done what other states have done. I don't know why California is coming up last, even on having doulas available. I'm looking at Thomas's face. And please, if you have designations and you're a doctor or anything, and I haven't acknowledged that, I always love to do that, but I don't know. So, but I just want to respect you in that. But I'm watching Thomas's face, and Michael, thank you for the question. But we will share more information because we need more advocates and we need more professionals that are willing to say, yes, why wouldn't we support this if it's going to reduce death and disease? And like Abner shared, the increase, it's going to cost more if babies are in a NICU. I'm working with someone that's at UCLA. So thank you, Dr. Medell. She's at one of my daughter's friends. I was a teen mom, so my daughter's 35. So one of her friends had a baby again 15 years later after having her son. So she's 35, 36, had a baby 3 months early, had a situation because her son, she didn't know he had diabetes and he was having an episode. She called for help and thought to maybe do even a 5150. Then she became involved with DCFS, sadly. So then she found out she was pregnant. A lot of stress around that led her to having her baby 3 months early. So baby Joy Linda's at Ronald Reagan Medical Center in the NICU. She's about 18 days old, just had like a PDA. And I've been supporting her mom, in this journey to say, we're here, we're behind you. But that's my support as a doula, not looking for funds, but to even get in the work to support other doulas and lead people to those who are advocating and supporting. But we could do better. So we're bringing DCFS to the table and having these conversations. I'm sitting with them and talking about racism and implicit bias, and they're doing training with some of their staff about this. So those are the ways we can really look at where is the intersectionality and start to advocate and do work around that. So I hope I answered your question, Michael. And
Can I ask one more small follow-up?
Yes, sure.
I feel like it'll be right over the plate for you, but it seems like one of the ways that one of the drivers for Black infant mortality and Black mother death is the experience of racism. It seems like doulas are at a unique crossroad for being able to build support systems around people, decode and decompress some of the experiences of racism in the system, and being able to help people feel supported, loved, and cherished. How do you see the doula's role in kind of mitigating some of the impact of racism?
You have said just that. It is being that voice and being present, and being the extra ears, right? You go into the doctor, many of us know we may have had a list of things we were going to talk to our physician about. By the time you get there, you're nervous, you may have been anxious, maybe somebody, even the receptionist wasn't as lovely and kind, or maybe, someone cut you off in the parking lot, whatever. Now, your heart's racing, your BP is higher than it should be, and you may have a whole bunch of other things on your mind, besides the fact that we have a population that is really impacted when it comes to housing. When people come to us, we have to assume that they have everything, right? Our biases say they have everything, or they may come along and we're like, oh, here's another pregnant woman. She doesn't have any support. She's unmarried. All these things we assume, not knowing anything. And so we enhance a horrible situation that people don't even need in that time. They just need to feel comforted going through this journey. Body is changing, and the doulas come in and can be that voice and hear those other things, right? The ones you want to question later, not to challenge a physician, not to challenge a nurse, but to say, are some of these things medically necessary, right? We have too many unnecessary C-sections that lead to some of the other issues down the road, right? Especially, and then, just having the time, that the nurses and doctors, you guys, they tend to be on a clock to see patients, you got 10, 15 minutes with these folks, and then you got to get them out. And so that too is where doulas can come in to support, that role, not to give medical advice, but to support and educate, right? And they've had great success. And talking about some of the things that the physicians and nurses don't have time to go over with the patients, like, reminding them about their nutrition, reminding them about, if they have mental health needs, referring them to other providers, and looking at support groups and ways in which they can get involved. That, is critical and crucial.
Thank you, everybody, for such an insightful discussion. I want to make sure that you all have an opportunity to take your break, bio break, water break, whatever you need. So we will resume at 3:15. If you'd like to hang around, certainly do that and continue the discussion. Otherwise, please go ahead and take your breaks and we'll resume at 3:15. Thank you again.
Thank you, Adjoa, Abner, and Medell. It was great.